Okay, good morning, everyone. Looks like the rain slowed the in-person attendance this morning a little bit, but that's okay. Hopefully, you're all joining from Zoom. So we have two great talks this morning. The first is endurance surgery, the management of massive PMP. I don't quite remember what PMP stands for, but I believe it has something to do with Pseudomyxoma peritonei, right? This talk will be given by Dr. Steve Ahrendt, professor of surgery in the surgical oncology division. I've actually known Dr. Ahrendt for many years as we trained together when we were both residents together at Johns Hopkins during our general surgery training. He did his undergraduate training at University of Illinois and then his MD at University of Chicago, where he graduated AOA. In addition to general surgery training at Johns Hopkins, he also did a surgical oncology fellowship with Dr. Cameron there. He's been on faculty at Johns Hopkins, Medical College of Wisconsin, Rochester, University of Pittsburgh, and in 2017, we were extremely lucky to recruit him here to the University of Colorado. He has 120 peer-reviewed publications. At Pittsburgh, he really built, I think, the busiest HIPEC program in the country and maybe in the world. And thankfully, he's come here to the University of Colorado, and ours is beginning to rival the program at Pittsburgh and becoming one of the busiest programs in the country. He's an excellent technical surgeon, and he's a great teacher, and I know the residents really enjoy these endurance surgeries with him. And with that, Steve, I invite you up. Thank you.
Yeah, thanks, Rich. I was just commenting to Gretchen over dinner last night that it's exactly 5 years since we started working here, and certainly happy to be able to share some of what we've accomplished over those 5 years in terms of cytoreductive surgery. I have no disclosures. The objectives of this morning are to review the pathological classification of mucinous appendiceal neoplasms, which are behind the vast majority of what we call Pseudomyxoma peritonei, to discuss the current definition of resectability in Pseudomyxoma peritonei, or PMP, and to determine whether the limits of resectability can be safely extended in patients with this disease. Mucinous appendiceal neoplasms are rare. There are approximately 127 cases of breast cancer among women in this country, among 100,000 per year. There's about 38 cases of colon cancer and about 13 cases of pancreatic cancer per 100,000 population per year. Appendix cancer is well less common than that. There are about 0.12 to 0.9 cases per 100,000 population. If one goes by the general guideline of 1% of appendectomies have cancer, that puts it at about 2,500 per year in this country. And if one uses a 0.5 number, it comes out to about 1,800. Not all appendix cancers are mucinous. A little less than half are. The mucinous tumors and signet ring cell cancers. So there's probably in the neighborhood of 1,600 cases per year in this country, and that is spread across all stages, so we don't really know how many are stage 4 or have disseminated around the peritoneal cavity. This is what it looks like. This is a appendix, which is somewhat dilated. You can see the mucin exuding from the base and causing a little mass there. And then up at the right-hand corner of the screen, you can see some momentum that's replaced with mucinous tumor. So mucinous appendiceal neoplasms are sort of classified into 3 grades: grade 1, grade 2, and grade 3. This was a grading system put together at the University of Pittsburgh to simply characterize these tumors, and it's very important in establishing prognosis. Grade 1 tumors cytologically look like normal mucosa, essentially. There's no abnormal features cytologically, no loss of polarity, there's no lymphovascular invasion. and they're essentially benign-looking cells in the wrong place when they get into the peritoneal cavity. Grade 2 and grade 3 tumors are more like typical cancers. Grade 3, at the worst end of the spectrum, is made up of and defined by having signet ring cells. And then grade 2 tumors have the usual characteristics of malignancy, high-grade cytology, high cellularity, and destructive stromal invasion. This is what the grade 1 tumors look like. On the left, on the top, is normal intestinal mucosa. On the serosal side, on the downside of that image, you can see just a normal-looking mucosa with a glob of mucin next to it. It's just in the wrong place. And on the right side, the mucin can dissect down a little bit into the tissues. It's not invading per se, but that's sort of what we see intraoperatively, is the mucin being stuck essentially to different structures. This is at the opposite end of the spectrum, the signet ring cells shown on the right, and on the left you can see these glands invading through the stroma, and this is a traditional invasive cancer. So we looked at the prognosis in patients. These are all stage 4 patients who underwent cytoreductive surgery, and the grade really determined the long-term survival. With patients with grade 1 tumors having at least an overall survival, there's no real fall off until beyond 5 years on those survival curves. Grade 2 and grade 3 tumors, there is certainly diminished survival. The treatment of mucinous appendiceal neoplasms with dissemination around the peritoneal cavity is cytoreductive surgery with HIPEC or heated intraperitoneal chemotherapy. As I explained to the patients, it's sort of broken up into 3 phases. The operation, the first is the tumor resection. And essentially the goal of the surgery is to get all of the tumor out of the peritoneal cavity, what we call a CC or complete cytoreduction. After that, we use heated intraperitoneal chemotherapy. The protocol here does that treatment for 100 minutes. And theoretically, it's a way of achieving a high local chemotherapeutic drug concentration right where the at-risk surface is. There's enhanced cytotoxicity if you raise the temperature to 41 to 43 degrees Celsius. The tissue penetration of most of the chemotherapeutic agents is only several millimeters into the tissue, so the treatment is not going to be effective if you don't reduce the tumor substantially in size. So the management of mucinous appendiceal neoplasms is defined really by the grade. For grade 1 tumors, it's really the surgical procedure with the intraperitoneal chemotherapy. For the higher grade tumors, grade 2 and grade 3, they're more traditional cancers, so we combine it with systemic chemotherapy. With the grade 2 tumors, we usually do the surgery first, and then following recovery, treat like a standard colon cancer with 6 months of systemic chemotherapy. The grade 3 tumors are a little bit trickier. They can present either with the typical features of Pseudomyxoma peritonei with spread of mucin and throughout the peritoneal cavity, or sometimes it's a more infiltrative tumor, and those tend to be the more clinically aggressive patients. Those patients we tend to favor giving neoadjuvant chemotherapy, and once they've been treated, if they've had a significant response, then we offer those patients therapy. This is an example of the more infiltrative type of grade 3 or signet ring cell cancers. This is a patient where the tumor is very infiltrative. You can see it covering the small bowel serosa here. It's also sporadically on the small intestine. This is a patient who's probably not going to be resectable. It's hard to appreciate that on a CT scan, so we use laparoscopy fairly liberally to decide which patients are going to be candidates for surgery, at least at this end of the spectrum. There are a few terms that we use in trying to describe the results of surgery to sort of compare different studies to one another in individual patients. These are 2 of the key prognostic factors in cytoreductive surgery. One is the extent of the disease before you do surgery. That's what we call the peritoneal carcinomatosis index. It's a simple scoring system that divides the abdomen up into 13 zones. 9 of those shown on the left are just anatomic divisions, and then the small intestine is divided up into 4 zones. So for each zone, you measure the amount of tumor. If there's nothing there, you score it a 0. If it's less than 5 millimeters, you get a 1. If it's between 5 millimeters and 5 centimeters, you assign it a 2. And if collectively the tumor is more than 5 centimeters, you get a 3. So if somebody has massive tumors, they'll be pushing 39 on that score. And the other significant prognostic feature is what's left when you're done with the operation, and that's what we call the CC, or completeness of cytoreduction score. If there's no tumor left, you assign it a 0. If the tumor deposits are less than 2.5 millimeters, you get a 1. For most real cancers, if you're not getting a CC0, patients aren't going to do well. For the grade 1 tumors, there is certainly a palliative benefit if you have a CC1 resection or even a CC2 resection. But CC2 resections are between 0.25 millimeters and 2.5 millimeters, and then greater than 2.5 centimeters, it's a CC3 resection. So we looked at patients that had high volume disease back in Pittsburgh and reported on this now 5 or 6 years ago. But what we noticed in managing patients with extensive grade 2 and grade 3 disease was that the rates of incomplete cytoreduction certainly went up as the extent of disease, or the PCI, went up. And our CC0 resection rate fell above a PCI of 20 from 67% to 31%. And as you're dealing with these more extensive cases, the blood loss goes up, the time of the surgery goes up, the need to do multiple GI resections and reconstructions goes up, and along with that, the morbidity of the surgery goes up. For patients who had more than one GI anastomosis, in this group of patients, the reoperation rate was about 24%, the fistula rate was 35%, the ileus rate was 35%, wound complications 35%, so very morbid surgery. And we also look back at the rates of survival, those patients having complications, and this has been shown for other major abdominal cancer surgery as well. The long-term results of the surgery from a cancer perspective diminish as the surgery complications increase in frequency. And when we looked at the survival in this group of patients, interestingly, the patients that had high volume disease that we were able to achieve a complete cytoreduction in, so that roughly 1/3 of the patients, their survival was comparable to the low volume, high grade patients. But the patients who had an incomplete cytoreduction, who had high grade disease, didn't fare very well, and their median survival was only about 12 months. So this is what a typical patient with PMP looks like. This was a patient I followed throughout my time in Pittsburgh. He presented in 2008. Interestingly, he had a colon resection for stage 1 colon cancer. They didn't do anything with the mucin in his abdomen, referred him to us afterwards, and we addressed that with cytoreductive surgery, HIPEC, cholecystectomy, splenectomy, and we're able to do a complete cytoreduction, and he was doing fine when I left and moved here 9 years later. And if you look around his liver, I don't have a pointer here, do I? Well, in any event, around the caudate lobe and the porta, you can see there's really very little tumor. And most patients will have the anatomic distribution of their tumor that looks something like this. But what about a patient like this? This was one of the first patients I saw here in University of Colorado. He was a 73-year-old male. He'd been labeled as having cirrhosis just because of the appearance of his liver on the CT scan, and also with congestive heart failure just because of the abdominal girth really inhibiting venous return. He had significant lower extremity edema. And with the abdominal girth, he was really unable to lie recumbent, and he's in your office and he says, "I can't live like this." So what do you do with a patient like this? Well, there have been some studies looking at what the extent of resectability is in patients with Pseudomyxoma peritonei. This is a recent study out of France, and several of these senior authors are also senior investigators in the landmark PRODIG-7 trial that looked at HIPEC and colon cancer, and recently has been published. And they looked at 126 patients with PMP at 2 major centers in France, in Paris and in Lyon. And they collected 126 patients over a 9-year time span between 2006 and 2014. And they determined resectability in patients. They needed to fit 3 criteria. One, they had to have enough small bowel left after the resection to not develop short bowel syndrome. They needed to be able to preserve the proximal stomach by saving the left gastric artery. And they also needed to be able to clear disease around the porta hepatis for patients to be considered and to go ahead with resection. And they were able to resect 93 of these patients, 70 with a CC0 resection, 23 with a CC1, and about a quarter of their patients they felt were non-resectable. And when they looked at their CT scans, they came up with a radiological score, which was the sum of 5 distances all around the liver. And they're shown here in the graph. They looked at the amount of disease between the portal vein and the IVC, splitting the falciform ligament between the caudate lobe and segment 3 of the liver, between segment 3 and the lesser curvature of the stomach, and between the back of the caudate lobe and the diaphragm. And if they measured the amount of disease, they came up with this radiological score. And looking at their group of patients, they came up with a cutoff of 28, where if the sum of those diameters of tumor was over 28, all those patients were under, or significant amount were unresectable. The median score was 0 in the patients they were able to resect, and all of the resectable patients had a score of under 25. And with this score, they felt you could predict whether you'd be able to resect a patient, avoid morbid surgery in patients who are unresectable, and then go on or consider a stage procedure in somebody with massive disease. So here we are back to this patient we saw here. If you add up all those things, you're well above 28, you're at 154 millimeters. So, what do you do with this patient? Did you just palliate him, or what do you do? So let me just take a step back here. This is, how did I get into this business anyway? I was 10 years out of practice in 2005, or 10 years out of residency, when we were being recruited to the University of Pittsburgh. And as you're sort of going through the interview process, I really wasn't familiar with this operation, but as you're going through and talking to different people, they put, some residents on your schedule. And generally what I got out of the division of oncology, surgical oncology, were there, that they were doing this procedure called cytoreductive surgery, and the patients were in the hospital forever. They all had fistulas. And ultimately we accepted the job, and obviously within a few months of being there, somehow I was incorporated into this group of surgeons who were doing this procedure. And anyway, the leader of that program, Dave Bartlett, shown here on the right with his wife, Susan. This is actually at the last international HIPEC meeting, getting some fresh air after the conference. But he has been a real innovator in this type of surgery. He was, up until recently, the division chief in Pittsburgh. But he, beyond Paul Sugarbaker, whose name is associated with the procedure, has done probably more than anybody else to develop the field. And as you can see in a publication here on the lower left, the volume at Pittsburgh was very high, and he was sort of known for taking on the tougher cases. So early on, when some of the leading cancer centers had sort of limited entry protocols and who they would entertain doing the surgery on, we really were sort of doing this on a lot of patients and really being able to figure out who this procedure would benefit and what patients it would be helpful for the most. So when I moved to Pittsburgh, I simplified my life. I realized that my research career was not going anywhere. I got rid of the research component of my practice and really devoted myself to doing clinical work. And over the 10 years we were there, I also became interested in doing endurance athletics, and it was a great way to sort of participate in cycling and running with my family and taking great trips to do races and vacations. Along the way, in doing all that training, the endurance mindset is not that unlike what we do in surgery. And if one goes back to that study on the resectability, they never really say why those patients weren't resectable. And as you're doing these operations, you realize that if you're making progress and you're going along, it's really just a matter of time. If you have enough time, you can get all the tumor out. And the mindset has to be somewhat like what you do in endurance surgery. For Ironman racing, for those who don't know, it's a 2.4 mile swim, 112 mile bike ride, a 26 mile run. And at some point during that time where you're starting to do the run, you realize that this is not a good idea. And those are sort of the thoughts that go through your mind when you're doing an operation, like this operation is never going to end. But if you sort of realize, and for Ironman racing, there's a cutoff at 17 hours, which is, as it comes down to it, about the amount of time anybody's willing to stand at an operating room table and sort of keep one operation going. That's about as long as I can last. But if, as long as you're making progress and putting one foot in front of the other and taking one little bit of tumor off the liver, eventually you'll get there. And you sort of realize that a lot of patients, the only thing that's keeping them from being resectable is how much time the surgeon is willing to spend doing the operation. So back to this guy, what do we do for him? Well, we took him to the operating room. The plan was just to get him through, getting the bulk of the tumor out and then come back and do what we call a stage procedure to finish the job up down the road. And he went to the ICU. He was here for 28 days. I was kind of under the impression that I'd be asked to leave and find a job someplace else. But ultimately, he left the hospital. And in like 2 or 3 weeks later, he walked into the office and he said, "I've never felt better in 10 years. And for whatever reason, he was sort of delayed the second operation, but this is what his liver scan looked like roughly 16 months later with really very little, if any, disease present on that scan. So what I want to do is share what we've done in 5 years with mucinous appendiceal neoplasms here at the University of Colorado. So here I'm going to review all of the patients with mucinous appendiceal neoplasm, SAS-PMP. There are, I think, 1 or 2 patients that had a different primary, but the same phenotype with the mucin. And we're going to look at the complications and survival in patients that are going this extensive long-term surgery here. And this is what the disease looks out on the right, buckets of this mucin that we remove, and the lower panel is probably an ovary that's replaced with tumor. And this is sort of the breakdown of the patients. We saw 124 patients here in roughly almost 5 years. We did 147 cytoreductive operations on them. 9 patients we had to abort on basically because of disease extent. Only 2 of those were grade 1 tumors. So the vast majority of grade 1 tumors, you're able to get at least a CC1, CC0 resection. Only rarely is it so invasive that you can't make progress. So 112 had their first initial attempt at curative surgery here. 19 then went on to a second procedure, of which 16 of the 19 were resectable. And then there are 3 patients that have had 3 procedures, 1 patient has had 4 procedures. And if we divide patients into those which were on the shorter phase and by the longer phase, and I just took here as a dividing point those patients that were longer than the operating surgeon's average Ironman time, and we give it 2 groups that will sort of answer the question of how bad the patients with the longer, more extensive surgeries do. So most of these patients going in, we were doing curative intent surgery. 85% roughly in each group. This was their initial attempted surgery. The additional patients in the group were undergoing their second, third, or fourth surgery. A lot of these patients have had prior attempts at curative surgery elsewhere before they had their cytoreductive surgery here. It's about a 50-50 spread between male and female, median age 60. The ASA score and the grade differentials are not that different between the two groups. Among the patients that had the long surgery, about 26% had really disabling symptoms. That is, they had a bowel obstruction, they were admitted to the hospital with a bowel obstruction, or they had such massive abdominal girth that they really couldn't eat anymore or lie down. And if we break down the operative time by the PCI or extended disease, this is what the graph looks down. And when I put down the RS score, I was able to calculate it for 30 of the patients having their initial surgery in the long group, and this is what it broke down. And we were able to achieve, shown on the right, a CC0, a CC1 resection in a lot of patients that were above that RS of 28 cutoff that the French group identified. If we look at the operative details, the long group, the PCI was much higher. Our ability to achieve a complete cytoreduction went down, but it's almost impossible to get a CC0 resection. There's just so much tumor, and it's just around every appendix epiploica in the abdomen that there's always just a little speck of something left. So we almost assign a CC1 to these extensive PMP patients. 70% of the patients had a RS score above the cutoff of 28. And the blood loss was higher, the number of patients getting transfused was higher, the operative time by definition was higher. And we used HIPEC on about 3/4 of the patients. The main reason for not doing it in the long patients was we felt that 2 hours was better spent removing additional tumor rather than doing the HIPEC. The operations, the long operations are certainly more extensive. They included more diaphragm stripping, which leads to pulmonary complications, a lot of liver capsule resection or caudate lobe resection, splenectomy, and doing a gastrectomy were much more common in the long surgery group. This is the breakdown, at least by GI anastomosis. In the long group, 76% of patients had more than 1, 2 or more GI reconstructions. 2/3 had a low anterior resection, and among those patients, we used a loop ileostomy more commonly in the patients undergoing a more significant surgery, but that is a much lower percentage than what we used to do in Pittsburgh, where almost everybody got a diverting loop ileostomy. This is a paper Bobby presented several years ago at the SSO, and we showed that the complication rate goes up the more extensive the surgery. Other factors such as the 90-day readmission rate are certainly much higher in patients having a high PCI and more GI anastomoses. And these are the postoperative outcomes. The length of stay was roughly twice as long. The ICU admission initially after surgery was much higher in these patients undergoing the long operations, but the ICU readmission rate, the overall ICU length of stay, the readmissions in 90 days, and the operative mortality was not significantly different between the two groups. We had 1 death among all the patients at 30 days, and then there were 4 deaths outside of the hospital within 90 days of surgery. Complications were much higher in the long surgery group. Most of these patients, we just started on TPN shortly after surgery. They're sort of defined as having a grade 2 ileus complication, but if you take those patients away, the complication rate is still higher among patients having the extended surgery. And these are specific complications. The reoperation rate was only 6% in both groups. The IR drainage was used a little bit more commonly in the long surgery group. A lot of those are just sterile fluid collections that develop after extensive surgery. The one complications we did see were pulmonary emboli and DVTs that seemed to be higher in the long surgery group. And finally, looking at survival, the typical things that break out as being significant also were significant in this group. The PCI determined survival, as did the completeness of cytoreduction here. Those patients having a complete cytoreduction had a significantly longer survival, both recurrence-free survival and overall survival. And grade also seemed to be significant, with those patients having low-grade tumors having a better survival than patients having a higher grade, especially on the right in recurrence-free survival. We probably just haven't followed it long enough to see that difference on the left in the overall survival. And getting then to the length of surgery, if one looks at the short group versus the long group, those patients having shorter surgery with less extensive disease tended to do better, both from a standpoint of recurrence-free survival and overall survival, as shown on the left. But if one looks at the long surgery group, overall survival, it's still at 50% out 3 years from the surgery. The key determinants of that end up being grade. If one looks at the grade 1 and the grade 2 tumors, the recurrence-free survival was not significantly different, nor was the overall survival shown on the left. And both the long and the short groups appear to have a 3-year overall survival, more than 75%. The patients that didn't fare so well were those with the higher grade signet ring cell cancers. Of that group, there were only 8 in the long surgery arm. 3 of those are still alive now without disease, but 5 of those tended to progress fairly rapidly. So this again is just another illustration of This is weird. Anyway, the pictures don't match the case, unfortunately, because the pictures are pretty dramatic. But this was a 48-year-old female who came in again, similar to us, with just massive abdominal distension, and she was diagnosed early on during COVID and had disease confined to her abdomen, but during the 3 or 4 months while she developed COVID and recovered from COVID, the disease extended through her diaphragm and literally filled up her right chest. And she came in, had a fairly extensive surgery, PCI of 36, liter of blood loss, OR time pushing 12 hours. She was in the hospital 28 days, mainly for a huge ileus, but went home on TPN, came back 2 months later, had her ileostomy taken down, and her scan looked great afterwards, and she was literally down to 83 pounds just because she couldn't eat for so long before surgery, and had gained 38 pounds in the past year, and her CEA level is back to normal. So in summary, CLS HIPEC can be safely performed in patients with massive PMP from mucinous appendiceal neoplasms. The postoperative morbidity and length of stay are increased, but are acceptable without a significant increase in operative mortality. I just wanted to thank Bobby Torfey and Felix for collecting a lot of this data, Anna Gleisner for putting together the database, and the nurses and PAs and the MDC that take care of all these patients. And especially the surgery residents who suffered through these long cases with me. That just shows the growth of the program.
So, Steve, thank you very much. I think we're out of time for questions. So if you have questions, go ahead and email Dr. Ahrendt. And, in listening to your talk, I just have one comment. I don't think the RS score makes any sense, right? Because it seems that it's more about consistency and perseverance of the surgeon. And just because you have, an extra couple of millimeters between the caudate and, the rest of the liver, I think consistency makes a big difference. I mean, how easily does it come out?
Yeah. I mean, a liver like that probably takes 8 to 10 hours to clean all the disease out around it. It's time consuming.
Yeah.
I think that's the main the main issue there.
Yeah, time.
Yeah.
All right. Well, thank you for bringing such a great program to the University of Colorado.